Hello and welcome to today's podcast, where we will be discussing differentiation syndrome, a potentially life-threatening complication in the treatment of acute promyelocytic leukemia. As treatment paradigms have evolved from atra chemotherapy to atra-arsenic combinations, questions around prevention, optimal management, and the role of steroid prophylaxis have become increasingly important for clinicians. In today's podcast, Dr. Yasmin Abaza discusses the biological basis of differentiation syndrome, the rationale and mechanism behind steroid prophylaxis, and how the supporting evidence has developed over time. She also explores how steroid prophylaxis is applied in current APL treatment protocols. We conclude with a brief commentary from Yannis Valtis on emerging therapeutic approaches for differentiation syndrome and the need for prospective trials to better define their role. So, without further ado, let's head to our discussion with Dr. Abaza. Dr. Abaza, thank you so much for joining us on the podcast. Can you begin by introducing steroid prophylaxis and the mechanism by which it prevents differentiation syndrome?
So thank you so much for having me today. So steroid prophylaxis in APL is something that's been first introduced in the 1990s, and it really was the reason for its introduction was that with introduction of atra in 1988 and subsequently of arsenic in 1990s, these agents, in addition to transforming APL from a very fatal disease to a very curable one, they have revealed a serious and potentially fatal complication, which, as we all know, is differentiation syndrome. And that's really what prompted the development of strategies to mitigate that risk, including the development of steroid prophylaxis. And there is a very long history of how that became into action, and I'm happy to go through that story if you want me to, very briefly.
Yes, that would be great. Thank you.
It's an interesting story. So the very first case series that described differentiation syndrome as a novel complication of atra was really in the 1992, and it was done by Frankel et al. In the Sloan Kettering group. And what they found is that they had about 35 patients with APL who received atra monotherapy, 9 of which developed differentiation syndrome. And what they noticed is in the first 5 patients, they all required transfer to ICU, mechanical ventilation, and when they died, they found that post-mortem, their lungs had infiltrations with maturing myeloid cells, which is quite characteristic of what we see with DS. And when they looked at, what they noticed that the 6 out of the 9 patients that developed DS also had leukocytosis, and they realized even with the treatment of the leukocytosis with pheresis, cytoreduction, that really didn't help the respiratory distress once it was established. And after the first 5 patients went to ICU, the next 4 patients, what they did is that they used high-dose steroids, which was dexamethasone 10 milligram BID for 3 days. And what they've noticed that when they started it very early at the early onset of dyspnea, they had a symptomatic improvement and they had full recovery in 3 out of the 4 patients. And that was the very first report to recognize that, to recognize and establish that the early recognition of differentiation syndrome and its immediate empiric therapy with high-dose steroids can decrease morbidity and mortality from this syndrome. And that was sort of, they, later on published on even more patients, 78 patients, and they found the exact same thing, is that when they used the high-dose steroids, it was associated with a significant reduction in the incidence of and severity of DS. And that's really how the preemptive use of high-dose steroids at the time, the first sign of DS, was, sort of initiated. However, when it came to prophylaxis, that was a little bit more controversial as to how, when to do prophylaxis and even if prophylaxis is even necessary. And the very first group to look at prophylaxis, even before the start of the symptoms, was the Australian group in 1995. And they looked at 19 patients with a low white count, so less than 10,000, received atra monotherapy. And what they did is that once the white count rose to above 10, even if they're asymptomatic, they started them on high-dose steroids. And they did that for 12 out of the 19 patients. And what they found is that there was no pulmonary toxicity in these patients despite a rise in the white count. And this low incidence of pulmonary toxicity did suggest that this prophylactic use did benefit these patients. So suggesting that was the very first study suggesting that steroid prophylaxis may decrease the incidence and severity of DS. And that's really what prompted many of the subsequent studies to introduce the selective use of steroid prophylaxis in patients once the white count rises above 5 or 10,000, either before or during after therapy. And that's really how the steroid prophylaxis, really started to become in place. Subsequently, of course, we then have studies that looked at using it for all patients irrespective of white count, such as the LPA99 study and Lococo studies and others, and which use prednisone for all patients. I think the only caveat to using the prophylactic steroids for all patients versus it for selectively for higher white count, which these studies have shown, is that when they compared historically the cohorts, this is not randomized, but they looked at the studies that looked at using dexamethasone for an elevated white count versus using it for all patients, there is no difference in the mortality rate from DS, and that's where the controversy still remains. Should we use prophylactic steroids for all patients irrespective of white count, or should we only use it for patients at high risk for developing DS, which are the patients that start to develop leukocytosis? And that's still a gray area which we don't have good answers for.
Wonderful. Thank you for sharing that background. Could you now discuss how the evidence supporting steroid prophylaxis has evolved over time, particularly with the shift from ATRA chemotherapy regimens to ATRA arsenic combinations?
So, as you know, the arsenic is also associated with differentiation syndrome being a differentiating agent. Of course, the combination is definitely going to result in differentiation syndrome. I mean, what has evolved over the years is that, there's a lot of studies like the LPA 96, 99, 2005 studies that looked, and there's, of course, the Lococo, there's the Burnett studies, and there's a lot of heterogeneity in these studies. For instance, they looked at the LPA 99 study where they used prednisone prophylaxis for all patients, which is the 0.5 milligram per kilogram for 15 days, irrespective of white count. And they compared the outcomes of these patients to the LPA 96 study, which gave only steroids at the time of leukocytosis. They found that with giving these patients steroids, giving the prednisone for all patients was associated with a lower incidence of severe DS, but that lower incidence of severe DS did not translate into an improvement in survival. So, or an improvement in DS-related mortality, to be more specific. So, to this very point, there's still a lot of heterogeneity in how we do steroid prophylaxis, and it still remains unclear what's the best prophylactic steroid regimen for DS. If you look at the literature in the Lococo studies, the MD Anderson group, the Island protocols, the Burnett studies, you'll find that prophylaxis has been done very using either prednisone, methylprednisolone, dexamethasone. They either gave the steroids for the entire duration of induction. Some of them only gave it for the first 5 to 15 days. Some of the studies used the prophylaxis for all patients irrespective of white count, while others only used it in patients with white counts above 5 or 10,000, either at presentation or during induction. And to this very date, there has been no head-to-head comparison between using selective prophylaxis versus prophylaxis for everyone. So to really answer the question is how to best give steroid prophylaxis in APL. In our practice at Northwestern, and I know other centers across the country do the same, we sort of use the LPA99 protocol where we do prednisone 0.5 milligram per kilogram daily for all patients irrespective of white count for the first 14 or 15 days of therapy. And of course, if at the first sign of DS, once the patient starts developing dyspnea or having any issues with breathing or issues with creatinine, anything that would tell us that there is a concern for an impending DS, we sort of go up on the dexamethasone. We go from the prednisone to dexamethasone 10 milligram BID as a treatment for DS for at least 72 hours. And that's really our practice at the current time, at least at Northwestern. But there's still a lot of variability, and there's no consensus still about how to best do steroid prophylaxis in APL.
Lovely. So where does steroid prophylaxis fit in today's APL treatment protocols, and what controversies or unanswered questions remain regarding who should receive it and when?
So, as I said, the only, it's been 3 decades now since the first description of DS. There's a lot of issues that we still don't know. First of all, differentiation syndrome still relies on very non-specific clinical findings. We don't have any certain biomarkers or, pathognomonic signs or symptoms. All we know at the current time, and that's been shown repeatedly, is that the high-dose dexamethasone at the first sign of DS has been the only intervention shown to significantly decrease mortality. Using prednisone prophylaxis for all patients, irrespective of white count, all we know is that it decreases the incidence of severe DS, but it has not improved mortality rates. And therefore, there's still a lot of unanswered questions. We still don't know, is steroid prophylaxis needed for all patients, or can it be selectively used in patients at high risk of developing DS, such as elevated white count or high creatinine? We still don't know what is the best type of steroid dosing and schedule that we use for prevention. And one still area of controversy, although albeit not as high up there, is, do we need cytoreduction for all these patients? Do we need hydrea, anthracyclines, GO, with the elevation of white count? And does the cytoreduction provide any benefit to prevent DS in these patients with leukocytosis? Although that last point is somewhat less controversial, there's some data to suggest that using cytoreduction does decrease the risk of DS. And I think most institutions, including ourselves, we definitely use cytoreduction in these patients. But there's still these areas can remain controversial, still remain unanswered. And there's a lot of efforts, like in the IWDS, is to bring experts across the country to try to come up with the strategies of how to really mitigate the risk of DS, especially now with the emergence of multiple differentiating agents such as menin inhibitors, FLT3 inhibitors, among others, that are associated with a similar syndrome, which are associated with differentiation syndrome, and put patients at risk as well.
That's all my questions. Thank you very much for sharing your insights on the podcast. Now, Yannis Valtis will briefly comment on some novel treatment options for differentiation syndrome and the need for trials to assess efficacy.
There is not much evidence, and so a lot of what we are thinking about is rather speculative at this point, and we really do need trials to assess kind of how these different agents will work. But what we know is that differentiation syndrome can be a pretty dangerous toxicity of some of the novel agents for acute myeloid leukemia. Specifically, differentiation syndrome with menin inhibitors seems to be a little bit different than the differentiation syndrome we're all familiar with from ATRA and from the treatment of APL. And so there is a lot of interest in thinking about what other agents can we use. Of course, we all use steroids to both prevent and treat differentiation syndrome, and then other cytoreductive agents like hydrea and other agents can be used. But I think my specific interest in the field is that because I spend a lot of my time in cellular therapy and work on cell therapy patients, is can we take some of the agents that have been shown to work in the cell therapy context and bring them over to differentiation syndrome? And I would say the answer is I don't know yet. I think this is a very interesting question, but I want to be very clear that we don't have any evidence that these are going to work. I think that there are IL-6 blocking agents like tocilizumab and cetuximab that might have a role in the differentiation syndrome. There are interferon gamma blocking agents such as emapalumab that might have a role. There is anakinra, which blocks IL-1. And so all of those agents could have a role in the treatment of differentiation syndrome. I would say based on current evidence, I don't think we should be using those agents outside of a clinical trial. And certainly we should only be considering their use in a biomarker-driven approach. So if the IL-6 is very high in a patient who is having differentiation syndrome, I think it's very reasonable to consider an IL-6 blocking agent, but I wouldn't do that without a biomarker-driven approach.
Thank you for listening to today's podcast. We hope you found it informative. Be sure to follow us on X at VJHemOnc and subscribe to our podcast on Spotify, Apple, or Podbean. Until next time.